Hello, anatomy friends. This is Dr. Alsip, and in this video, we are going to be focused on the bones and joints of the neck and the back. And this is a rather long video. We have lots to get through. So let's go ahead and get started. We have four rather detailed learning objectives to work through. I want you to make sure that you keep these in mind as we work through this material together and come back and answer these in your own words. So we will start with the hyoid bone, which is an unpaired bone located in the anterior and superior portion of the neck. So if you're palpating your own neck, um, generally the very first thing you'll feel is the thyroid cartilage, so that laryngeal prominence of the top portion of the larynx. You would have to move superior to that and press pretty hard. Sometimes I kind of move my chin down in order to feel the hyoid bone. Pressing really hard on the neck obviously can be quite uncomfortable, so I don't suggest doing that unless you can feel it a little bit easier. But it's pretty high up there, right underneath the mandible. This is a small bone with a relatively wide body and small projections. So you have the lesser horns that are coming kind of right off the body region, and then you will have the greater horns that are projecting posteriorly. The hyoid bone is unique in that it does not articulate with any other bone. So in other words, it's not forming any joints. But it's not just floating in the neck, rather, it is suspended by tendons of muscles as well as ligaments. So it has attachments to the mandible, it has attachments to the thyroid cartilage, the sternum, and other structures as well. And through these attachments, it supports the tongue and structures of the neck, such as the larynx and the pharynx. The hyoid bone and neighboring cartilages of the larynx may be fractured during a strangulation event based on the placement in the anterior neck. All right, we will spend the rest of our video discussing the bones of the vertebral column, and there is a lot to discuss here, as this is such an important but also a really complex region. Now, you may have heard of the term vertebral column. This is a bit more complex than just the bones, which are called the vertebrae, but it also includes the connective tissues that is located between the vertebrae and assist in the articulation between these bones. And the bones of the vertebral column have many functions. Probably the most intuitive one is that the vertebral column protects the spinal cord and the associated structures of the spinal cord, so that's fully protected within this vertebral column. Most of the vertebral column is movable. So in the cervical through the lumbar regions, we're able to flex and we're able to extend as well as laterally flex or bend the vertebrae. And rotation is allowed as well to a certain extent. And one thing you will notice immediately on the vertebrae is that you have all these projections kind of all over the place. And these are going to be important in terms of muscle attachments to allow for those movements we just described. And then lastly, the vertebrae will bear weight. The more weight they bear, such as in the lumbar region, the larger the vertebrae are. So they get quite a bit larger in this lumbar region because it's bearing almost all the weight of the body. The most typical pattern of the vertebral column is to have 33 vertebrae that are organized into 5 regions. So from superior to inferior, these regions are going to include the 7 cervical vertebrae. These are going to be in the neck region. You'll have 12 thoracic vertebrae in the thorax or thoracic cage region, 5 lumbar vertebrae in the lower back. I always remember the movable vertebrae as the times I eat during the day. So if you think about it, I eat breakfast at 8 a.m., I eat lunch at 12, and I catch the early bird special at 5 p.m. for dinner. So that's how I help. That's kind of a helpful thing to remember those. There are going to be 5 fused sacral vertebrae, which form the sacrum. The sacrum is part of the pelvic girdle, so it's articulating with the hip bones. And then you'll have 4 fused coccygeal vertebrae that are going to form the coccyx. So these are very atypical vertebrae there. So let's talk about what a typical vertebra has, which I have typical here in quotation marks because vertebrae vary in size and other characteristics, and we will get into that level of detail shortly. But most vertebrae will consist of a vertebral body, a vertebral arch, which will be subdivided into regions, and most vertebrae will have 7 different processes. So let's start with the biggest part, which is going to be the vertebral body. It is generally the largest part of the vertebra, and it can be quite massive, particularly in the lumbar region. And this is because it supports the body weight as well as gives overall strength to the vertebral column. And it makes sense that they get bigger as you get to the lumbar region, because imagine them having to deal with progressively greater body weight. The bodies begin to decrease in size and become irregular in the sacrum and the coccyx because the weight gets redistributed to the lower limbs, so you're not having that same level of weight bearing. The vertebral bodies are also the most anterior portion of the vertebra. And for the movable vertebrae in the cervical, thoracic, and lumbar regions, there'll be intervertebral discs located between the bodies. And we've talked a little bit about this before, but it's primarily composed of spongy bone with that outer layer of compact bone. The vertebral arch is posterior to the body of the vertebra and consists of 2 short pedicles that are going to project posteriorly. The pedicles meet 2 broad flat plates of bone. These are called the laminae, and the laminae meet in the midline. And when you put the body and the pedicles and the laminae together, you get the vertebral foramen, which is that relatively large hole in the middle of the vertebra. And if you put all the vertebral foramina together in an articulated vertebral column, you get the vertebral canal, which is just that succession of vertebral foramina. Sometimes you hear this referred to as the spinal canal. And this canal, as you might imagine, contains the spinal cord, so a major part of the central nervous system. But it will also have spinal nerve roots that project from the spinal cord, and these are going to be the first part of the peripheral nervous system. Also located in the canal are the meninges that cover and protect the spinal cord. You'll have epidural fat, which is superficial to the dura mater portion of the meninges. And within the adipose is going to be vasculature that supports this region. And then between layers of the meninges, there will be cerebrospinal fluid, or CSF, which functions to cushion and provide buoyancy to the nervous tissue, as well as to play a role in terms of chemical stability in this region. Moving to processes, and there are going to be 7. The easiest for me to identify is going to be the spinous process, which is going to be the most posteriorly projecting, and it will be unpaired. So it is located in the midline and projects from the junction of those flat plates or those laminae. And if you run your fingers down the midline of your back, you are feeling or palpating your spinous processes. Now, projecting posterolaterally, you will have the paired transverse process or transverse processes when you're talking about both of them. These are projecting right at the junction of the pedicles and the laminae, and there can be quite a bit of variation in terms of the size and the shape of the transverse processes in the different regions. These projections, all of these projections I just described, are going to be important as attachment sites for deep back muscles. Moving to articular processes, you are going to have 2 superior articular processes and 2 inferior articular processes. So there will be a facet on the superior articular process that will articulate with a facet on the adjacent inferior articular process. So these are all going to form these facet joints that are also important in terms of movement of the vertebral column. Lastly, we have intervertebral foramina, which are formed by the superior and the inferior notches, plus the intervertebral discs in these regions. And they are going to run down the sides of the vertebral column. And these are going to be really important pathways for the exit of spinal nerves from their source at the spinal cord to eventually reach their target organs. Additionally, you're going to have dorsal root ganglion, or DRGs, that are going to be located at the level of the intervertebral foramina. These are going to be sensory neuron cell bodies, which you will learn more about in the neuro portion of the course, but it's important to note that these are located in that region as well. Let's turn our attention to the different regions of the vertebrae and how we are going to be able to tell them apart. And it's important to note that all vertebrae are unique, but most vertebrae, they'll have characteristics that would categorize them into one of 5 regions. So not every cervical vertebra looks exactly the same, but there are certain characteristics that all cervical vertebrae share that isn't the same as what you'll have in other regions. So our most superior vertebrae are going to be these cervical vertebrae, which form the skeleton of the neck. They are movable, meaning that there are joints between these vertebrae that facilitate and allow movement. In fact, the cervical vertebrae are generally described as the most mobile of the vertebrae, although the lumbar are relatively mobile as well. Of the movable vertebrae, these are the smallest, and that makes sense that they're smaller because they're not bearing as much weight as the more inferior vertebrae. So cervical vertebrae are supporting the weight of the head, but not of the upper limb or the thorax region. So really, it's just bearing that relatively small amount of weight. There is one very easily observable structure that will make it easy to identify a cervical vertebra. And this is going to be the transverse foramina. So put stars and hearts, however you want to remember that these are important. And these are going to be these oval or round shape foramina that are in the relatively short transverse processes of cervical vertebrae. Even the unique first and second cervical vertebrae have transverse foramina. And vertebral arteries and veins pass through these foramina on their way to the foramen magnum of the skull. So these vertebral arteries are one of the major arterial supplies to the brain. So very important arteries that are well protected by the cervical vertebrae and their ascent towards the brain. Due to their overall smaller size, the cervical vertebrae have relatively smaller vertebral bodies. And the spinous processes may also be what's called bifid, or divided into 2 smaller projections at the end. And if this does occur, it usually isn't all the cervical vertebrae. Usually it's like C2 or C3 to about C6. C7 usually has the longest spinous process in the whole vertebral column. It's not bifid generally, and this is often called, C7 is often called the vertebra prominens because you can palpate that really long spinous process, and that sometimes can help count out vertebrae. But again, for me, it all comes back to these transverse foramina. If the vertebra has one, it is definitely a cervical vertebra. If you do not see a transverse foramen, you are definitely looking at a different type of vertebra. There are 2 cervical vertebrae that are so unique that they need to be discussed separately. The first is the first cervical vertebra, often just called C1, or sometimes you hear it referred to as the atlas. Think of Atlas in Greek mythology holding up the world on their shoulders, while C1 is holding the head on its shoulders or surfaces. And the bone resembles a ring. It's very unique in vertebrae in general because it does not have a vertebral body. It also does not have a spinous process. There may be a little projection there, but not resembling the full spinous process like in other vertebrae. And C1 forms two types of joints. Superiorly, it articulates with the occipital condyles at the atlanto-occipital joint. So this joint allows us to shake our head, yes. Inferiorly, it will articulate with C2 at the atlantoaxial joint, which is a pivot joint that allows us to shake our head, no. Speaking of C2, it is a unique vertebra as well. It is often called the axis because it has a projection, which is the axis of rotation for the atlantoaxial joint. So the specific portion is called the dens or the odontoid process. And the dens will project from the vertebral body of C2 and articulate with C1 to form that pivot joint. Moving to thoracic vertebrae, there are 12 thoracic vertebrae, which very conveniently match up to the number of ribs we have per side. And these are named thoracic because of their association with the thorax. These can also be described as being in the upper back region. Thoracic vertebrae are movable, but of the movable vertebrae, these are the least mobile because of the attachment to the ribs and being part of the overall thoracic skeleton. The most distinctive characteristic of thoracic vertebrae are costal facets or costal demifacets or half facets. These are located on the lateral side of the vertebral bodies and the transverse processes. And these facets allow articulation with the ribs. Specifically, the vertebral body articulates with the head of the ribs, and the transverse process articulates with the tubercle of the rib. So if you see a small, smooth articular surface on the body or the transverse process of a vertebra, you are looking at a thoracic vertebra. And as you might imagine, the size of the more superior thoracic vertebrae are similar to cervical vertebrae. And if you are, say, at T11 or T12, they will be much bigger, about the same size as a thoracic vertebra. So let's move to those biggest of the bunch, the lumbar vertebrae. These are located in the lower back region, and there are only 5 of these, but these 5 are very large and they actually take up a considerable amount of space. And this is because the weight they support increases towards this inferior end of the vertebral column. So in particular, the bodies of the lumbar vertebrae are comparatively massive. And these are also your most inferior of the movable vertebrae. L5 will articulate with S1, or the first sacral vertebra, with an intervertebral disc between their bodies. And from there inferiorly, the vertebrae of the sacrum and the coccyx are considered immovable. They have fused together. Distinguishing a lumbar vertebra from the other types is relatively easy because of its massive size. I also use the distinguishing features of the other types to help identify if the massive size isn't enough. So lumbar vertebrae, they do not have transverse foramina like the cervical vertebrae, and they do not have costal facets like the thoracic vertebrae. Unique to the lumbar vertebrae are the almost vertical articular facets of the articular processes, and these facets are going to be directed medially. But really, their size is their most distinguishing characteristic. So those are the movable vertebrae, and I want to quickly mention the immovable vertebrae again, which form the sacrum and the coccyx, because they are part of the vertebral column, but we will actually discuss these in more detail with the pelvic girdle, so more to come here. Now, you might picture the vertebral column as a straight column, but when you look at a vertical profile from the lateral side, of this column, there are going to be observable curvatures or bends in the vertebral column. And these curvatures are actually very important in increasing the strength of the vertebral column, as well as helping to maintain balance in the upright position, which is very typical for us, as well as absorbing shock during walking and helping with resiliency, so protecting against fractures. So we actually want these curvatures, although we will talk about in a moment there can be over curvatures, which are pathological. To be specific, there are going to be 4 curvatures. The thoracic and the sacral regions are going to be called kyphotic curvatures, which the concavity is going to be anteriorly placed. And then the cervical and lumbar regions are lordotic with a curvature more posteriorly, or kind of a bulging out anteriorly. These can be further differentiated as primary and secondary curvatures. So in the fetus, there's only one curvature. You have an anterior concave curve for the entire length of the vertebral column. Think about being in fetal position. So that is that primary position, and the thoracic and the sacral region will stay in that position. So these are called primary curvatures. With changes in function, further curvatures start to develop with time. So around 3 months after birth, an infant begins to hold its head erect. And with that, anterior convex curvature in the cervical region will start to develop. So that's why this is considered, that cervical is considered a secondary curvature. What do you think would cause the lumbar curvature to develop? So think about activities like sitting up, standing, and walking. These will develop that lumbar curvature secondarily. So that is why the cervical and lumbar curvatures are considered secondary curvatures, because they form later. And generally, curvatures are developed by around the age of 10. Now, even though these curvatures are natural and good, they can become atypical or exaggerated. Excessive thoracic kyphosis, sometimes just called kyphosis, although the naturally occurring and typical curvature is also called kyphosis. So I always like to add in this excessive when I'm discussing. So this would be an over increase in the thoracic curvature. Kyphos means hump, and sometimes, unfortunately, you hear this referred to as like a humpback. This can be caused by many different issues, things such as tuberculosis, which may cause partial collapse of the vertebral bodies, rickets, poor posture. These can all cause excessive kyphosis. A common cause is also advanced osteoporosis, with that spongy bone being lost in the vertebral bodies, which will amplify that curvature. You can also have excessive lumbar lordosis. Sometimes you hear this as hollow back. This is often characterized by a noticeable anterior tilting of the pelvis. And this is often associated with weakened trunk musculature or things such as sudden weight gain, such as what happens during pregnancy. It can be caused by other factors as well, such as rickets, osteoporosis, or tuberculosis. And a lateral curvature to the vertebral column anywhere, but often it happens in the thoracic region, is called scoliosis. And there are many different causes of scoliosis. It may be congenital or present at birth, so the vertebrae are malformed, causing this curvature. It can also develop, could be caused by a weakness or paralysis of muscles. It can be idiopathic without a known cause as well. So any lateral curvature is referred to as scoliosis. And let's finish our discussion of the vertebral column with the joints, the intervertebral discs. And these are symphyseal cartilaginous joints located between the bodies of movable vertebrae. So it's important to note that there's no IV disc between C1 and C2. Remember, C1 doesn't have a body, and there's that pivot joint there. But from C2 and C3 down to L5 and S1, there are intervertebral discs between every single set of bodies. And these joints account for about 25% of the height of the vertebral column, and they increase in size as you get more inferior. And each intervertebral disc is composed of two different regions. The outer portion is composed of fibrocartilage and is called the annulus fibrosus. Notably, it's going to be thinner posteriorly, so that's an inherent area of weakness. The inner portion is called the nucleus pulposus, which is semi-fluid, kind of a mucoid type of substance. And with age, this inner region becomes less hydrated. So you may have heard the term slipped disc. This is actually referring to a herniation of the nucleus pulposus through the annulus fibrosus. And this typically happens in a posterolateral direction. But as can be visualized in this image on the left, when this herniates in this direction, that's right towards the spinal cord, as well as the more proximal portions of the peripheral nervous system. So the spinal nerve exiting that intervertebral foramen. So it can compress upon this nervous tissue, and that can lead to pain. Sometimes it can lead to weakness in muscles. So it can cause all types of different issues. And because the lumbar region bears the weight of the body, it is a fairly movable portion of the vertebral column as well. So herniation is most common in this region, particularly between L4 and L5 or L5 and S1 levels. That's the most common areas. All right, we have finally made it to the practice question. We have covered a lot. And so let's assess our understanding in one of these areas. So the question is, you are trying to identify the type of vertebra you are looking for. And you notice that there are costal facets on the body and transverse processes. Which type of vertebra are you looking at? So what we need to remember here, kind of a key in this stem, are the costal facets. Remember, they have to do with rib articulation. So which vertebrae articulate with the ribs? And hopefully you remember that it is the thoracic vertebrae that articulate with the ribs, and they have these costal facets. So that would be the correct answer. Now, what would be a distinguishing characteristic for a cervical vertebra? Remember, those transverse foramina, that's their main defining characteristic. Coccygeal vertebrae, they're very unique, they're very small, they're pretty easy to identify. Lumbar, they're notably big. They do not have transverse foramina or costal facets. The sacral vertebrae, they're fused. They form the sacrum. So again, very distinct there. So all signs point towards E, thoracic being the correct answer. Excellent. Thank you so much for your time and attention.